Okay, so we are moving on. We are about to introduce, I love her too. I just love everybody here, okay? So we're going to introduce Dr. Monique Gary. She is a board certified, fellowship trained breast surgical oncologist and medical director of the Grandview Health Penn Cancer Network Cancer Program in Sellersville, Pennsylvania, where she also serves as the director of the breast program. Dr. Gary is the only African American female breast surgical oncologist in the state of Pennsylvania. Today, she is going to talk about utilizing patient advocates in the healthcare space.
Am I live? Can you see me? Okay, perfect. Just gonna share my screen in 1 second, but I'm so happy to be here. So excited to see you. Oh my goodness. This is truly an honor. I'm so thankful for the opportunity, and I would love to say, yes, share my slides. Here we go. That I am no longer the only Black female breast cancer surgeon in Pennsylvania. We have another. She is the chief of breast at Penn Medicine, Dr. Lola, and I am just I'm excited, because it's time. 11 million people in the state, and share we go. Share my screen, and we got to do better, and we have to do better for our sisters, and for all of our patients. So, if you can see this screen, I hope that you can, because I can't see you. All I see is my PowerPoint, and I see that StreamYard is sharing.
Just go full screen on your slides, please.
Boom, there it is. How's that? So I'm Dr. Monique Gary. I thank you so much, Shante, for the introduction, and thank you to Jamil for the opportunity to speak with you guys today on a topic that is really near and dear and essential, and it's something that needs to be explored in greater detail, which is utilizing patient advocates in the healthcare space. So how can we utilize our advocates better? And what do successful models look like? How do we benchmark success? How do we create systems that are reproducible and scalable, not just at an institutional level, but on a national level, and then on a global level? Like, this is something that is central to everything that we do. It's the patient, right? But not just the patient in active treatment, but those patients all along the continuum, and their advocates as well. And they have to be, again, you'll hear me say this a lot in this talk, they have to be not an afterthought, but really in the forethought, and in the inception of so much of what we do, in order to more fully ensure success. So we're going to talk about it today, and I'm not going to get into a ton of disparities data and background stuff. You guys have heard it, you know it, you're part of the organization, but we know that when we talk about disparities, particularly in oncology care, the disparities are real. The differences in incidence, in mortality, in late stage diagnosis, in quality of life issues, in survivorship, in thrivership are very real and distinct, and they have been examined exhaustively from a payer-payee standpoint, from the perspective of where people live. We've parsed it out by cities, by region, by what insurance they have, and all across the board, these things persist. And so it speaks to the fact that it is truly multifactorial. And because there is no single there's no single issue struggle here, as Audre Lorde says. We don't have single issue struggles because we don't live single issue lives. But that also means our solutions cannot be single issue. They cannot be myopic. And the role and the importance of advocacy, again, just cannot be understated. I love this article from Cancer Causes and Control 2019. And they looked at the predictors of breast cancer mortality among white women, Black women in the United States, city by city. And what they found was that the issues and the disparities are greatest where people, of course, have the lowest socioeconomic status, where they have the least amount of education. So those who've only graduated from high school, places where there are more FCHQs, the federally funded health centers and the clinics, that there are differences in the imaging centers and the types of imaging and the access to imaging that some women receive within those cities and within those communities. And so all along that pathway of how a person develops cancer in the systemic sort of medical world, not in the biologic world, not in the patient world, but how a person gets categorized and diagnosed with a cancer. There are opportunities for advocacy throughout that. So whether it's in screening, it's in diagnosis, treatment, the care continuum, and then beyond that, research, utilization management, there are resources available, but who has access to them? And are they being fully utilized and actualized within those areas? Policy, global implications as well. The global imperative, I love this. This is data by Sloan, but also by Joyce O'Shaughnessy, who probably brought this together in a large study that looked at lower and middle income countries and the need for advocacy within those countries as well. So it's not just here, but it is abroad. And there's a need to support the cancer community by helping to set up networks within these countries. And, our really good friend Sheila McGlown does a great job of doing the global outreach and advocacy because, these are women who may have to walk for days to get care, and a diagnosis to them is fatal, not only physically but also in their mind. And there's a sense of fatalism that precludes them from participating in clinical trials and from seeking out therapies that might be more aggressive but also potentially could be life preserving, life sustaining. And so there's some opportunities here even on that global level. So I think it's good to look at what the standard definitions are, and probably this group and maybe a couple others really may want to get together once more and generate a white paper of sorts that talks about the role and the definition of the patient advocate. This is one that I found from, I think, ACS, and the role of patients in the areas of clinical care, health policy, and research. That's the definition. Seems to me to be a little thin. But the way the groups are organized and structured according to the research is that they're informational, supportive, research, or political. So these are the advocacy groups. So the groups that are informational share disease and treatment specific knowledge. We see them, they provide pamphlets, things in our clinics. There's online information, there may be support groups. The supportive part, medical, psychological support, we're finding more that there's financial support that is not only needed, but able to be provided through advocacy groups. Research, participate in shaping the research agenda. And I love the way they phrase this, right? Because it's not just participating in research, but participating in the shaping of the agenda for research. And then on the political level, influencing the legislation and regulatory decisions. So that part I get, but what you find are that organizations such as yours are really all of these things, right? Like you can't just be one of them, because as soon as you provide information, you're going to realize that people need support and they need to be able to do something with that information that's actionable. And then you realize that there are barriers to that and that they need opportunities for financial and psychological support. And then you realize, well, there's a research gap. And then all of a sudden, well, what about the advocacy so we can get the funds for the research? So it's all very interconnected. And it can feel a little bit overwhelming for someone who is somewhat new to the advocacy space. And it equally can feel overwhelming to physicians who are advocates for their patients within the clinical spectrum. But then outside of that, they get very, very nervous. I know you have seen it. I know you have talked to doctors. And as soon as you mention, well, what about a therapist and this and that, and their hand gets on the doorknob and they're like halfway out the door, talk to my nurse navigator, see you later, and they're gone, right? It's a lot. It's a Medusa, but we all have to do our part, and it is all very interconnected. And so what a patient advocate is, I love this. Our very own Jamil Rivers on the cover of Cancer Today. And I put this here because a patient advocate is you. You know what it is. You know what it looks like. But I think it's important to also consider what it is not. Meaning there is a bit of a dichotomy in terms of the tensions and the relationship that an advocate must balance when they are helping someone navigate through their cancer journey. And the more intimately involved you become in advocacy work, you will find that there's some gray areas here, right? There's a little bit of tension between what is reasonably expected as an outcome, what's reasonably expected from that healthcare provider, and what may be beyond reasonable expectation. So there's an opportunity for that patient to figure out that shared vision with that doctor, and the advocate may be advocating for things that may not be realistic or may not be reasonable. I see this sometimes, not too often, once you meet a person and a family and a patient where they are. And so what I mean by that is, in my own clinical experience, when patients come in to my office with their advocates, with their data, with their articles, with their questions, we have to sit down and we have to parse out the information from these studies that's unique to that patient, and they may not know all the details, and so that person is advocating for something that may not be relevant to that patient. And so we have to see, where does it fit, maybe where does it not fit. And there's again the opportunity for building of trust. So I don't think this is a bad thing, this tension. I think that's an opportunity for trust. But then on the side of paternalism, not just on the part of the advocate, but also on the part of the provider, right? Everybody can't be doing what they think is in the best interest of the patient, because what's in the best interest of the patient is what the patient wants. And so we have to make sure that even in our advocacy work, we are always considering what it is that that patient wants, not what we want for them. Whether it's, I want to do surgery because I want to help you, I want to remove your stage 1 cancer that you're not going to operate on, or it's because, you know what, maybe we need to be a little bit more aggressive in pursuing chemotherapy, or having our ovaries removed, or doing other things. And I can't push for what you don't want, right? But we can develop a shared roadmap for whatever that patient wants, and the advocate is part of that shared vision and that roadmap. So my 2 cents are that advocacy requires and deserves really thoughtful consideration. It deserves lived experience. People who come in and try to be advocates and have no experience in either cancer treatment, cancer care, support, a cancer journey themselves, they can be allies, they can be trained, but it's hard to advocate for something that you've never seen and been a part of. It requires training. And what that training looks like, I think your society and your organizations are going to even more strategically and collectively begin to define. It requires structure. And I think it also requires accountability. As we generate more and more legions of patient advocates who are going out into our communities, into our cancer centers, into our support groups, I think that we should look to be accountable to and for each other, to make sure that the information we're providing is accurate, to make sure that we're not just telling people, oh, don't do that trial because of XYZ. Like, your lived experience is not necessarily enough. And that's where organizations like yours can come in terms of helping to train advocates to really know the data and understand how to apply that data, and how to be a help and encouragement to others. So that's my 2 cents. I think it's more than just showing up. That is certainly great for your loved one. But when we talk about programs of advocacy and the larger spectrum of advocacy, there's some things that we definitely have to consider. And it really is where preparedness meets that opportunity. I love that American Cancer Society did a recent study, and they kind of looked at 3 areas of intervention, particularly to reduce African American disparities. And it's not an exhaustive list, but it's a good place to start, I suppose. But it gives people an idea of what they're thinking in terms of where their priorities lie on the prevention and advocacy spectrum. And it looks like increasing access to the entire continuum of care. So from screening through treatment, through the entire journey. It looks like patient navigation. I think we've all identified the fact that when patients have some navigation, meaning somebody helping you through whatever aspect of the journey you're on, wherever you are, when you have a navigator, you are more likely to utilize resources. You're more likely to ask for things you need. You're more likely to get the things that you need, either for sustained living or for quality of life or for treatment continuation. And then talking about reducing the risk factors for breast cancer, there's a role for advocacy in that too. So in cancer care, on the spectrum of patient support, because we're going to break this down by patient support, research, and then legislation. And lastly, we'll talk a little bit about COVID, but there's some themes, right? Here in the US and abroad are the same. Trust. There's gaps in knowledge. There's stigma. There's this exchange of experiences that happens when we talk to an advocate, and all those things can lead to sustainability. And so, when we think about building programs in advocacy, we need to address the fact that there is an earned mistrust between our communities and healthcare providers. I think from the perspective of the healthcare provider, I need for organizations like yours to begin to help define what repair looks like. What does healing look like? What does trust look like? So that we can then aim for that, because I think we recognize, at least Black providers recognize, that the mistrust is real, and that everybody who goes to that oncology appointment doesn't get the same amount of time. They don't all get offered clinical trials. They don't all get offered the same resources. They may not have the resources where they are, right? We know that there is paternalism. We know that when we see certain patients, certain doctors will assume, I'm not going to offer that patient a clinical trial, even if it would be life-saving for them. And so there's an issue of trust. There's an issue of knowledge gaps within our community. And it's within every community, but particularly within our community, because there's a stigma of talking about our disease. And so we need advocates who are able to address some of these things in ways that would be empowering for patients to make decisions that are good for them. The exchange of experiences, one of the things I love about seeing more and more advocates is that we get to now share not only the horrible things that happen, not only the disparity, not only that doctor made me feel this, but you know what, I went there and I had a great experience and I changed my life and I changed my diet and I talked to my family and we're all on track now. We got our calendar of doctor's appointments and health visits. We got our naturopathic doctor we go see. We're doing our yoga and meditation. Like, it can all work together when we are able to share our lived experience, both positive and negatively. And that can lead then to some sustainability, because we can rinse and repeat and we can see some results. And so this came from a collaboration that Pfizer did. Pfizer did a collaboration with healthcare providers and with advocacy groups. And I think this was just last year in 2020. And they developed this exhaustive list. I'm going to make sure you have these slides. But there is an exhaustive list of what advocates can do in the realm of patient support, research, legislation. And so we'll kind of go through some of these, and then we'll leave some room for dialogue and questions and get into it more. But all of the things that are on this list are things that you're probably already doing. It is up to our organizations to begin to define how well we as an advocacy organization are doing these. How effective are we? What are the metrics? How do we measure success for these? And I think the Chrysalis Foundation does a really amazing job of beginning to quantify the impact of the advocacy on patients, on providers, on systems. But look at this, creating tools for patients to track the follow-up questions that they might have after they leave. Not only giving them tools after they leave, but tools for before they get there, right? Do you know what questions to ask when you get there? Encouraging the hiring of breast cancer navigators or nurses, personalized patient support tools. This one I love, second bullet from the bottom, and then the bottom bullet there as well. Offering healthcare provider training on how to share both good and bad news to patients in a hopeful yet honest and clear tone, and training on how to discuss medical terminology in lay language with patients. And you may think, this is not my job. My job is to support this patient. Our jobs are to do whatever we can, whenever we can, however we can, for the betterment of our people and our community and our patients and our loved ones. And there is a role for the advocate in even in medical education, especially in medical education, whether it's at the institutional level, being and serving on panels as standardized patients, as speakers and educators, or even beyond then, for the people who missed it, who didn't have that training in their medical schools, that are receptive and willing and wanting to be better providers. The part of that training has to come from the advocates. And so there's a role there that does support patients. Let's see. There we go. We talked about medical terminology, providing resources that encourage patients to write down their questions. This is great. Improving telemedicine so that patients are able to easily access and benefit from it. This is an area where we can certainly partner together with your healthcare providers, because in the era of COVID, more people than ever are now utilizing patient portals. They are now utilizing telehealth consults, and that opens up a world of accessibility to patients that previously might not have had access to certain institutions, to certain providers, like people of color. Black physicians are few and far between, but I've seen patients in consult from California now, because we can do telemedicine consults. And so even if they don't come to me for surgery, we can certainly review their imaging, review their diagnosis, review their care plan, and we can make sure that they feel empowered and they're on track. And that's That's all doable through our offices and our healthcare systems now, but making sure that people have access. If you don't have Wi-Fi, right? If you don't have a tablet, what can we do? And so there's room for patient advocacy, even with the cable companies, even with our local community groups and our local legislation. Peer-to-peer support groups for sure. Translation, this is big. Disparities exist not just in race. I have patients who are differently able, patients who are hearing impaired. Do you realize how hard it is to have a conversation with a patient who's deaf when your mask is not see-through? And they have to bring their translator every time. Patients who come from various countries where and the only information we have in our offices might be English, maybe Spanish. Well, what if you speak something else? Creating educational resources regarding palliative care really should be bumped up on the list. And this is in no particular order, but I mean, as you begin to think about what your advocacy work can look like for you, think about some of these things, because these are areas that are really, really, really in need. Use of mobile phone apps, translation, palliative care, not as an end of life option, but as an integral member of your care team to help you be able to continue therapies, have excellent quality of life, make sure that you're addressing the entire person 360, because each provider specializes in what they do. And so somebody's got to help be the umbrella. And we try very hard. As a surgeon, I try hard to let my patient know what they're going to expect when they go to medical oncology, what they're going to expect in radiation oncology, what are the resources available to them. But there is a division of medicine that can help with the very specific things that might keep you going on that trial just a little bit longer. So palliative care is a huge and should be an early consideration. And then create materials for children, adult children who act as caregivers, for partners, for spouses. And I use, all of these life partners, for chosen family, all of the different iterations of support. And I see very little information that reaches out to these people in culturally sensitive ways. You're with your husband or your wife, right? Or you're male or you're female. What about the gender non-conforming and the non-binary? And what about the partners and the others? And, there's some room for us, I think, to be more inclusive and room for advocacy in that as well. Encouraging patients, expanding access to translation, host a workshop on how to support patients experiencing poverty and or food insecurity. This one's a big one. And I think that, again, as you think about what advocacy activities you'd like to consider or ways that you can get involved, because really what you should be thinking from an organizational standpoint, picking out the most impactful of these, but from an individual standpoint, what can I do where I am with what I got? And food insecurity is a big one, and it's going to be a big one as we go into fall, as we go into winter. We are still with COVID. There are supply chain issues. And so I'm here to tell you that I think that we really need to focus a bit for the fall and the winter on food insecurity and making sure that people have what they need, that they have tips for how to maximize their budget and their diets, whether it's cooking and what do you do with your leftovers, or how to make really great, hearty, healthy soups. Now's the time. And that's an area where we can be of a great and tremendous support. Again, creating videos, focus groups, communication channels, education material, technology, how-tos, you name it, there's a role. In research, this is an area that there is gaining increased traction, increased funding, increased awareness ever since, I guess, the more vocal and visceral and apparent issues in Black Lives Mattering and healthcare disparities that COVID has revealed and really ripped the Band-Aid off of. It's starting to trickle back up the ladder to research. Ways that patient advocates can participate in research in oncology care at the academic level, certainly by participating in trials and sitting on boards, like I'm the chair of the Institutional Review Board or the research board at my hospital. And we need community members on our research board. And our board is not complete, and we will not do trials unless there are actual patients and lay people sitting in those seats who can identify with, approve, ask questions, and make sure that what we're doing is appropriate for patients. The larger cooperative groups. So every region in the country has a working group of researchers called a cooperative group. We have here in the Northeast ECOG, in the Southwest the SWOG, SWOG, and all across the country. And with industry, this is an area that's growing exponentially because industry needs advocates. One, in order to justify their expenses in cancer care, right? You make a drug, you can't just push your drug. You need to sponsor educational activities and events that are unrelated to those drugs. And so those dollars are earmarked now, not for you to push any particular drug, but for you to teach on disease processes. And who better to receive those resources and do that education than a really highly qualified and well-trained group of advocates, right? So this is time for these organizations to step up because there is funding. And so you have to position yourself in your organization. Collaboration is key because if every group goes with the same idea, well, we need to be innovative and we need to collaborate so that we can have a more sustained impact and a greater impact across our country and across our world and not just within our organizational sphere. And the last one is real world data. We need it and we need it now. We don't need to wait another 5, 10, 15, 20 years to find out what's working. We need to see how it's impacting patients in a relatively quick turnaround time. And so real world data, I know that METAvivor, for example, partners with Citizen. The Black Breast Cancer Alliance partners with Citizen. I think Chrysalis may do so as well. But there are organizations that are now becoming increasingly devoted to generating that real world, or rather real time data. And that's patient reported outcomes. So we don't know what the outcomes are unless the patients report them. Well, who has access to the patients and who can get them to actually participate in these sorts of non-drug registry trials or registries, collaborations? They're not all trials, but we do collect that data so that we can see how people are doing in real time. There's a great article that came out in 2018 from JNCI. And this is from the SWOG group, the Southwest Oncology Group. And they developed this framework for patient engagement in the Cancer Clinical Trials Cooperative Group studies. And I'll go into that in just a second. So in research, the peer review process. Peer review is not just for medical professionals, right? It's the accepted method for identifying the best or the most meritorious scientific trials and studies, but they have not included the advocates. And so ideally, the breast cancer advocates need to be included at all levels, the programmatic process, determining the priority areas for funding. DOD actually has done a nice job of making sure that the scientists and the advocates are partnering together in collaboration. And we'll talk a little bit about that in a second too. Clinical Trials Initiative, we know the imperative. It is a moral imperative. It is a physical, it is a real imperative. But if advocates are not involved early, right, they must be substantive collaborators in that process. And you need to help establish the criteria to evaluate if a clinical trial is quality. Right? You need to be the one to help us say, no, this is something that is a great model for patients, or these are the barriers. Here's where your study and your idea, it goes astray. In conception and concept, it sounds great, but here's how it plays out. And here are the challenges and the barriers. Because for too long, we found that we would design these great trials, or we thought they were great trials, and then we say, well, nobody signed up for it. It's because we did not consider the people who were directly affected by these trials early on. And my personal opinion is that it should all be directly linked to funding, and it is increasingly linked to funding. I'd love to see more of that in industry, whereby, you know, if you're going to get national funds, if you're getting NIH, NCI grants, if you're getting, you know, you got to make sure that you're not just checking the box and just, you know, getting that same minimum 2-3% African-American participation. We can do better. We can. And it comes through partnership with advocacy groups. You hold the key to the patients and to the not just the patients, but to the patient's understanding and the momentum and the purpose and the vision of where they can be from where they are. And that's the role and the importance of the advocate. Scientific meetings, absolutely, right? Because for too long, you go to the meeting and you kind of sit on the sidelines, or you might look at a poster or two, or, you know, you might stand up and ask a question in a symposium if you kind of got some of the data, but, you know, you were not at the table. You were not in the part of the program planning. session chairs, session co-chairs. I'm beginning to see more of this now, but it's still not enough. Right? There have to be opportunities for interaction between scientists, clinicians, researchers, and advocates. And then there has to be opportunities for us to present our work at the poster sessions, and not just at the poster, but at the podium as well. What you do is important for the scientific community to hear, not as an afterthought, not as just the coffee tea session on the last day when people are going home, right? But front and center, here is the patient advocate. Here is that experience. Here is where we fit into what you do. Because for too long, scientists have operated within these silos and vacuums where they don't see the patient, they see the disease process. And there's a person attached to that tumor and that diagnosis. There's a family. There's all the different considerations that we need to take into account as we do our research, and it makes it more robust. So here's the exhaustive list. I'm not going to bore you with all of it, but I'll again get you the slides, and you take a look at these things. If you're watching, this content and you're wondering, well, where do I get started in research? I guarantee if you pick something off this list and you call your local cancer center or the hospital where you got treatment or the one that's near to you, or you touch bases with, the sponsoring organizations of this event, they will say, yes, there's opportunities. We collaborate with NCI, and we always need people to help with lay language. We always need a patient testimonial. There's opportunities for you to get involved in all of these things. On the policy side, we need advocates to help our legislators understand where the fiscal and the moral and the medical imperative is, because the data does not always reflect it, right? If the data reflects the majority of patients who are living longer with breast cancer, then they're not going to put the dollars there, right? Until we amplify our voices in the ways that are important for us. And so that's where our advocates can certainly come in. You can collaborate with the advocacy organizations to allocate government to improve breast cancer care. We need legislation regarding screening. What are the screening guidelines, and how are we getting things paid for, like whole breast ultrasound and MRIs for patients who have extremely dense breast tissue or family histories and should be screened earlier, or Black women, period, who probably should be screened earlier than everybody, right? So how do we get from here to there? And a good bit of that's going to come through your advocacy work, telling patient stories, putting a face. What changes policy? Policies may change, but what changes practice is relationship. And so until you go and you put that face and you look like my sister, you look like my mother, when patients see me, right, they see the white coat, but then I start talking. And then I start sharing my story and talking about my family and saying, if I were sitting in that seat, or if I were your loved one sitting in that seat, and all of a sudden they know that I see them. I think the same thing is important at the legislative table, because whenever there's a policy, there needs to be a face attached to that. There needs to be a story. There needs to be somebody's kids. There needs to be a way for them to realize that the policies that you are either adopting or rejecting have real consequences on real people. And so there's a role. Training patients and advocates to communicate with policymakers. It's a different language, just like talking to researchers and physicians. When you don't get the ones who are able to speak your language, you got to speak their language. And so finding and training people to learn how to use the particular and the specific vernacular is very important. Seeking grant support for policy activities. Working with healthcare providers, again, advocating for policies that enable patients to share their experiences with regulatory authorities, accessibility platforms, and sharing best practices. So cultural adaptations around advocacy, equity in national cancer plans, right? Because everybody's insurance is a little bit different. And some people, for many years. So in the breast literature now, there's all these debates and discussions about Black women being offered plastic surgery. Well, or the rates and the disparity in plastic surgery, right? And what we're realizing is that they weren't offered it. So you look at 1980s, 1990s, 2000s, maybe insurance issues, maybe paternalism on the part of the physician, maybe they had more advanced disease and they needed things like radiation before they could get reconstruction. But there's all these factors. And so we can't just look at the problem and say, hey, Black women have less of this. There's an entire upstream system that made it so. And the policy work can help to relieve some of those structural barriers that we call, when we talk about structural racism, there's a structure in place that we all operate within. And the doctors are just moving through and doing their surgeries and giving their chemo and doing their radiation and seeing their patients in the clinic one after another. But there's a structure and a scaffold that has been for very long stacked against us. And so we have to begin to look at the ways to undo the structure in order to undo the effects. I love this one. This is I want to say Hutchinson out in Seattle, Harvard, and then a couple other hospitals over in Germany looked at invasive lobular breast cancer and how researchers, clinicians, and advocates can accelerate lobular breast cancer research. And so I'm not going to share the entire study, but what they did was define the schema here that says, here's where the researchers are, here's the clinicians, here's where we need our patient advocates to be effective. And so while the researchers are helping to define those priorities, the advocates are assembling and communicating educational research information on it and feeding that back to the researchers so that they can help to define really what is the priority, right? Designing the clinical trials, our advocates are not only designing it, but assuring integration of it into the conferences, the professional education, our organizations, our churches, our support groups, wherever and however we can. And so this is a great sort of schema, a little cartoon of how the patient advocate is an integral part of this. And they've seen some really great success in the research in lobular breast cancer. This is the article I was referring to, the JNCI article, looking at the Southwest Oncology Group. If the picture on your left really talks about how we used to develop clinical trials. So I got my little arrow here. So concept generation and development, then they pass it to the peers, they prioritize it, and they say, okay, we're going to go forward with this study because of whatever statistic that says this is important in cancer care. So then our investigator initiates the concept, and then the committee goes, and then they pass it over to this committee, and they pass it over, and they approve it, and they bounce it back. If it's not approved, where in here? Where are you? Where are you? And so they said, okay, let's reimagine this and let's figure out how we can engage our patients and our advocates. And so now it looks like patient advocates are engaged from here. So the concept, they really should be here, concept generation and development. And I think this is a great inroads for our organizations, our nonprofits, to inroad with the oncology working groups to start talking about concept generation and development. So we don't wait until we got the concept, right? Now they're initiating it and they engage the patient advocate. And then the patient advocate creates this project to say, yes, this should work, or yes, I think we can do this, or no, this is not exactly feasible in execution. Looks good on paper, but when you roll it out, people aren't going to show up because they got to take 2 buses and 2 trains to get there. And then it passes to the committee and it goes backwards, forwards, and backwards, and then ultimately gets funded or not funded. And so they have included now the patient advocate at all the different stages. My contention is that we got to go back even to here. COVID-19, and I'm going to wrap it up here. But COVID-19 has really shown us that we need our advocates and that you matter, not just in all the ways on paper, but you matter to people who are going through this experience by themselves, who feel isolated as a result of the coronavirus, who have challenges in their loved ones, right? Because we tend to be people who are essential workers. We tend to be people who don't have time off. We live in multi-generational homes sometimes. And so all of the things that impact cancer care have been crippled really by COVID. And we are anticipating an additional 10,000 deaths from breast and colon combined over the next couple of years as a result of the coronavirus. As a surgeon, I'm seeing more advanced disease, and I'm seeing patients who show up, they're afraid, they're alone, and they need advocacy and resources and good information more than ever. So there's a role for advocacy in advocating for prioritized rapid testing for cancer patients and caregivers, making sure that telemedicine is accessible, right? That there's a digital interface for these people in communities, especially for our older, our seniors, right? So working with local legislation and industry, maybe sponsoring a grant or something. Hospitals communicating with patients on proactive measures they should take. I think everybody's kind of doing that. Giving it and providing information and debunking myths, right? We not only have to give the good information, but taking people from where they are into the areas that they maybe didn't know. So I spent a lot of time talking about how to debunking the myths that people think about either vaccines or clinical trials or drugs or chemotherapy or cancer in general, right? Like there's a lot of misinformation around right now. And so we need a group of people who are committed to combating misinformation and not just providing accurate information. We need to go on the offense here. Emphasizing the importance of access to symptom control, right? Here's our palliative care consult early because you may not be able to make it back and forth to your cancer center. So we got to make sure that if you need IV fluids, you can get those at home or that you'll be able to go into your urgent care, not have to wait 10 hours or whatever to get what you need. And so advocacy here can also help. Collaborating with our organizations to host virtual support groups when our hospitals and shut down and we couldn't really take visitors. We then went virtual and we provided these online platforms and communities that have exploded with information and with people saying, oh my God, I thought I was alone. I never knew that. Oh my gosh, I went through this by myself. I wish I had known. Or has anybody ever heard of? And so now these are thriving online communities. I think the challenge will be figuring out how to take them back into the real world and stay connected with everybody. But making sure that these virtual spaces are available is important. Leveraging the technology to connect their patients with loved ones. Whenever somebody comes in by themselves to my clinic, the first thing I say is, who do you want with you on the phone? What do you have? What kind of phone? You got Android? We're going to FaceTime? Are we going to Zoom? Who are you calling? I don't say, is there, sometimes I say, is there someone you would like? But more times than not, I say, I encourage patients to bring an advocate or a friend or a loved one. It doesn't have to be a blood relative. Is there somebody? And who is that person? And should we include them in this conversation if you're comfortable with that? Do you need a resource or somebody in the room? So making sure that everybody has that opportunity and making a list of policy opportunities that have surfaced as a result of this. We have seen that screening mammography is down, way, way down. And guess where it's down? In our communities, right? And the screening wasn't already great before. We all weren't getting 3D mammograms. We were going to 2D mammogram buses, right? And not getting the best technologies even. So making sure that if we're doing mobile mammography, we have 3D units, making sure that people are aware that they should go for screening despite, and certainly for diagnostics. I can't tell you the number of patients who had an issue and they said, oh, well, they told me not to go because of COVID. Diagnostic imaging is always right. Always, always appropriate. I don't care if the whole world shuts down. If you got an issue, you got to get seen. And so making sure that we prioritize that patient and that they know that they're a priority despite what's going on with COVID, because who knows how long this is all going to be going on. But I think that making plans for our patients and our breasties and our loved ones is a really great thing to consider throughout this winter into the spring, because it's going to be here with us. So that being said, I think I am at time. In conclusion, we need you, medical community, industry, academia, research, policy, and there is funding. There's funding, there's opportunities. We need good ideas and we need structure and organization so that we can show that these things are working. You have the solutions because you've been through it all. And you know what works and you kind of know what doesn't. And so we need your wealth of knowledge, energy, and commitment to the process to really help drive things forward. And if COVID has shown us nothing, it's shown us that, the importance of the interconnectedness of all of us. So with that, I will stop. I will take questions. I'm going to stop sharing my screen. And thank you for inviting me.
Oh, Dr. Garrett, you're wonderful. You put tears in my eyes at some of the topics that you discussed. You gave so many tools today. I got into patient advocacy because of all the reasons you mentioned and just to kind of humanize the experience. Unfortunately, we don't have time for a lot of questions, but we really, really do appreciate your time and knowledge. You gave like a bunch. I don't think anyone even have a question for real. You answered them all. So I really appreciate you taking the time and giving us all that detailed information to help with the health disparities.
Oh, absolutely. And I'll make sure you guys have the slides so that if people are watching and want to do individual things and you don't know where to start, we got you covered. I'm Dr. Monique Gary on all social media. If you have any questions, if there's anything I can do, I love you guys.
Oh, we love you too.